can melt the hardest heart. You can warm the coldest light. You can heal the broken soul. Lord, I give myself to you. You can melt my hard heart. You can warm my cold life. You can heal my broken soul. Lord, I give myself to you. Why surrender to you? Those dark, cold places, you are my only hope. Hold me close to you. Let me know that you'll be there to get me through. Lord, you know that I can't get this heart, this mind and will. Help me lay down my pride and surrender all to you. Why surrender to you? Those dark, cold places, you are my only hope. Hold me close to you. Why surrender to you? Those dark, cold places, Lord, you are my only hope. Hold me close to you. Let me know that you'll be there to get me through. Let me know that you'll be there to get me through. Let me know that you'll be there to get me through.
Good morning, everyone, and welcome to another episode of Catholics at Home. It's so great to be here with you this morning once again on this Saturday morning where we come to you live right to your homes. Literally, that's what our podcast is all about, Catholics at Home. So wherever you are, welcome to episode number 83. Now, 83 episodes we have been going on for more than a year and a half. And we are glad that you are able to keep this Saturday morning with us to listen, to be a part of this. I just don't say listening to this talks or listening to these conversations, but a little community that I think we have kind of created here on a Saturday morning. So it's a beautiful day as I look out the window, bright sunny morning here in KL. Wherever you are, hopefully you are having good weather too. And as I said, it's so nice that you are able to. We have been so regular in that sense that everybody knows on a Saturday morning at 10:30, Catholics at Home podcast comes on live, And I know that so many people set aside this time. You put aside all other activities, and you kind of mark it in your mind that today is the day that we are going to have another conversation. But before we proceed, today I'm solo. The other hosts are busy. As you know, life is getting back to some sense of normalcy. People are also taking a short breaks to get out of the city, to do other things, to do things with their families. So this morning, here I am with you alone, but we will have a guest with us to speak to us on the topic that we have chosen this morning, and hopefully it's something relevant to you and also relevant to those who are seeking some level of assistance, especially in the area of addiction. But before we do that, I just want to call out some names. Let me just read out some regular names who join us. There's Ellen who joins us. Philomena, hi Philomena. Eric, hi Eric. Just let me see. Regina Arokiasamy, Sebastian Stanislaus, and so many. Vivian Kulasingam, Teresa, Augustine. Thank you so much. Thank you so much for joining us on this Saturday morning on this particular topic on addiction. Now, as for me, as I said, a lot of people are getting back to work, and they're doing other things, going out. People are taking short breaks. This morning I was out in the city. I see so many people out there jogging, cycling. So it's so nice to see that there's a kind of a change in our lifestyle too. This lockdown has kind of brought out the aspect of people wanting to take care of their health too. So it's so nice that to see so many different things happening back. And we also realize that our churches are opening. So as a priest, for me, it's so nice to have people back in church. For the past 18 months, it's like celebrating Mass alone. It's meaningful in its own way, but nothing like having a community to celebrate it with. Even though we are socially distancing from one another, we can't shake hands and do other things, but it's so nice to have a community, to be in a church, to be able to hear hymns, to be able to join and praise God. It's wonderful. So have you been back to Mass? If you have, I just want to ask you, what is the one word that would express your feeling? For those of you who have gone back to Mass, just type in our comment section, what is that one feeling that you, if you've gone back to Mass, let us know. How do you feel if you're at Mass when after so long we are going back to it? But we also realize that, as we go back to Mass, it's not like before. It's there are lots of things that you need to register, you need to scan, you need to take temperature, do all other things. Your seats are allocated. But we also realized that this morning, I just want to kind of give a shout out to the many people who work behind the scenes to help us get back to Mass. I would say that we priests definitely can't do it on ourselves. We have to take care of the liturgical celebration, but so many volunteers out there who are spending time to just organize getting people back to Mass. It's really nice to see people working together and welcoming people back. So I think as we come back, things are not perfect. We realize that things are not perfect. A lot of things, there are a lot of hiccups. When you go there, things maybe, the line is not there properly, your name is not there, or your seat number is not there. I'm just going to ask you, just be patient. Just be patient with our volunteers. They do give up their time to be there, to do all these things. And I would think that, just if you go back to church, I just like to encourage you, just, as you're registering yourself, just thank the volunteers. Just say, thank you for what you are doing. Thank you for making it, for helping us to come back to church. As I said, it may not be perfect. There's no point, being short fused with anyone at that time. Everybody's trying to phase people back into church, and it's not easy. So I would like to encourage you, if you are going back to church and you come face to face with the team that is trying to organize, register you, take your temperature, record, just say thank you to them. Thank you for what you're doing. Thank you for helping us to come back to church, and that will really make their day. They are so stressed in many ways. So do look out for them and say a nice encouraging word so that they continue what they're doing. To all those of you who are volunteers, who are viewers this morning, thank you very much. Thank you very much. I know it's not easy, but this is how we work together as a community as we come back to church. Having said that, just a little bit of a conversation of what's happening in our churches. This morning, our topic is dealing with addiction in the family. During this lockdown, there are many people who struggle who struggle. And addiction is one of the problems, so many different ways. Whether we already think of addiction as with alcohol or with substance or with gambling, but there are other forms of addiction too, sex, pornography, and many other shopping. Probably some people are addicted to shopping. It's been made so much easier during this lockdown. You sit in your couch and you are able to just, order this, order that. You become addicted to it. So this morning, we're going to talk to Dr. Philip George. Now, he is a consultant adult psychiatrist and also a specialist on the issues of addiction. I'm sure we have many questions this morning. How does one become an addict? What are the struggles faced? More importantly, how do we help? So if you are tuning in this morning, if you are struggling in that area, do stay on till the end of the podcast. If you have somebody in the family that you are trying to reach out to help, we could ask some questions to Dr. Philip. Do use the comment section to raise some questions. I think it is a good topic for us to just reflect and see how we can assist one another and to live the life that God has called us to. So it's my great pleasure this morning to invite Dr. Philip George to be with us in this conversation. Good morning, Dr. Philip George.
Good morning, Father. Thank you.
And how are you doing?
I'm good. I'm doing good. Thank you.
Thank you very much for taking time off from. I know you have a very busy schedule. As you said, people are lining up to see you. You have a tight schedule to see people. But just when I asked you, you are so generous and so willing to say that you will rearrange your schedule to be with us to have this little conversation about addiction, and we are truly grateful. Just about a month ago, we had this conversation, but in a different in a different platform.
That's right.
We were at the Asian Federation of the Catholic Medical Associations, and we talked about addiction, and you talked from the medical perspective, that I talked from the Catholic moral tradition. But we kind of did it, not conversation, but we all did it in a different way. You recorded your presentation, I recorded independently of each other. But this morning we had this opportunity for us to have this conversation. Let me just begin, Dr. George, in the sense that when we talk about addiction, we all have different perceptions of what addiction is, actually what amounts to addiction. Can you help us understand what is the typical textbook definition of addiction?
Yeah. Well, actually, Father, there is no textbook definition because the word addiction is really a layperson's term, colloquial term. The word that we use in textbooks and in criteria to make a diagnosis is dependence. So there are three different types of substance use. There's recreational substance use, and then there is substance abuse, and finally substance dependence. So take, for example, alcohol. If somebody is having a drink maybe once a week or once a month or on festivities, they're most probably a recreational user. They are not considered as having an illness, perhaps, except maybe when it goes beyond that single drink or a few drinks and it goes into a binge. Then they go on to being an alcohol abuser. When they drink more than 5 or 6 drinks in a single setting, more days than usual in a week, and that pattern's been going on for about a year, they've become an abuser. And with alcohol abuse, it can have impact on their family, on themselves, on that specific day, for example, or maybe in other areas of their life. Gradually, it starts picking up and building up into issues and problems. And then they may go on to dependence, which is what, we would typically maybe correlate as addiction, where it then becomes a neurochemical change in the brain and a gene change that actually takes them on to a chronic relapsing illness. So that's what we look at it as, in a medical model. Of course, there are many determinants for why people move down that path of, recreational to abuse to dependence. And those factors are, combination of biological, psychological, social, and even environmental factors. And that's why even in treatment, it's a combination of all these things to help people to, reach some recovery.
When you say neurochemical changes in the body, what does that mean? I mean, is something like happening in your brain? when
Yeah.
it's slowly becoming, as you move from recreational to be dependent on these.
Yes.
So I mean, yeah.
Yeah. So, I mean, basically, every substance that has a potential of abuse works on a pathway called the reward pathway in the brain. The reward pathway is in the oldest part of the brain. We have inherited our brain from, our ancestors, and as we developed and as there was, some evolutionary changes, our brain has modified and, changed to become able to do what we are currently doing, processing things, making decisions, adjusting things. But that old part of the brain is specifically meant for survival, and that part of the brain is has to have triggers that actually stimulate things that are known as rewards. So for example, if we think we don't want to eat anymore, we don't have the comfort feeling when we have a meal, or we don't lose interest in exercise, or even in having intimacy, that's the end of our species. So the reward pathway is essential for maintenance of the species. Every living animal has a reward pathway. Otherwise, they'll stop doing the things that are important for them to survive. But that reward pathway can also be stimulated by external things like drugs and like alcohol. And once they have been taken for a considerable period of time, which usually in our definition is 1 year, there are neurochemical changes in that reward pathway. It is blunted to the typical effects that maybe others get from going for a nice jog, or meeting friends for a dinner. They don't get that same emotional reaction and response as they would have if they weren't actually been using a substance for that long period.
So when you say that this changes happen because of substances, like for example, whether it's alcohol or whether it's drug,
Mm.
is it the same? Is it the same with other forms of addiction, whether it's sex, pornography, gambling? Because you're not ingesting something, but it's an external source. How does that work? Yeah.
Well, the same way that I mentioned and discussed about, for example, exercise. I mean,
Okay.
I had this patient who was a gym junkie, and she would do 3 hours a day in the gym. When her husband passed away due to some other circumstances, she upped her gym to 4 to 5 hours. Now, that's a hell of a lot of gym to do in a day, but it was her way of coping because it was triggering her reward pathway. But there's
Okay.
only so much the body can take. And after a while, it crumbles and it falls. I mean, you put more stress on your body, it starts to trigger off your mind, into not being able to cope. And she finally presented with suicidal ideas, thoughts, and depression. And she was severe depression. So, we had to start her on treatment, get her back to some normalcy of regular exercise, and break her away from that, uh, gym junkie sort of behavior that she, sort of went into. So that behavioral thing can also occur with various other things like gambling or
Mhm.
internet addiction or porn addiction, and also with, for example, what do you call video gaming. So when people use this as a way to escape or to cope, it becomes the new behavior that they can't sort of break away from. You know?
So something that starts off with a good intention, like you said, exercising, going to gym. I mean,
Yeah,
I would really look at this as somebody going to gym so diligently and
yeah,
working out,
yeah,
or even for that
yeah,
matter, maybe a glass of red wine that starts off, say it's supposed to be
yeah,
good for your health, etc. Uh,
yeah,
Something that can be triggered also, that it can take its own course in the sense of you becoming dependent on it. But when we look at
yes,
all these different forms of dependence or
mm,
addiction, I think you alluded to it earlier, but if you could explain it, why is it that some people, what triggers that some people become addicted and some people don't?
mm,
Is it self-control, or is it the circumstances, or is it because
yeah,
the way we are? Or what
mm,
happens in that process? Why some do become and some don't?
yeah. Well, I think the best way to explain that is maybe to give a case example. So, a patient that I often describe in my lectures to my students is a patient that I had, his initials RK, who was about 13 when his parents were going through a divorce, and he was moving school as well at the same time. So there are a few different adjustments that he had to make in his life. And the usual thing that most parents think is, well, he's just a kid. What does he know about stress? He won't be stressed, you know, which is, the most bizarre lie that parents tell themselves about their children. In fact, we know that youth and adolescents have the highest stress among all age groups. And the second most common cause, second most common cause of death among youth in Asia Pacific region is suicide. And we've seen that with this COVID, lockdown, we've seen suicide rates soar above the roof, and the biggest proportion was actually youth. So, when we neglect them at that age, they're left to their own devices. They then look to peers. And, they may have been a good student, they may have been on the straight and narrow, but they're under stress and they don't know how to cope. And so then the peers say, look, why not have a cigarette? And they start off with, maybe a cigarette or two. And then because they're vulnerable at that moment, they don't become that, oh, I don't like this cigarette thing and I throw it away. The experimenter. They're not an experimenter anymore. They're vulnerable and they move on to the next stage of, let's try and buy a packet, and then let's maybe have some alcohol with it. And so they start with these illicit drugs, which are maybe readily available in your coffee shop and, sundry shop, and no one's checking to see what age they are and everything else. And, enforcement doesn't play a big role enough. And then they're already in that ethos of people who are hiding and scheming and doing things that are dangerous to themselves, and they can't tell their parents, can't tell their teachers. And then it's so easy for others to come in and say, try some weed, or why don't you try some heroin, And that's what RK did. He got into heroin at the age of 17, starting with cigarettes, going on to alcohol, then on to weed, and got into heroin, which is one of the most addictive substances in the world. And after the first or second dose, he was already dependent on it. He thought, as most youth think, that they're in control, that, he'll be able to switch off and, be back to normal. And, because, he's at that age, you are immortal, you can do anything. So, you can change life and do everything. And, but he slowly realized he had to inject and he needed more money and he had to steal. And he stole from his mom, he stole from others. And then he realized it was way beyond what he could cope. So he came to his mom and asked for help. Now, looking back at the history, his dad was a smoker, used to drink a bit heavily on weekends. So he had some genetic predisposition, because it can be genetics. If you have a blunted reward pathway, like we discussed earlier, and that reward pathway doesn't get stimulated by things that normal people get stimulated by, then when you use a substance, you find, wow, this is a wonderful experience. And you become more prone to develop a dependence compared to maybe someone else who, had a buffet lunch and say, woo, this is the best thing I ever had. So it varies according to genetics. It also varies according to, so it doesn't have to be the specific drug. The father can be a smoker, the son can become a heroin dependent. So, those are things. Plus, it also is the vulnerabilities that individuals have. Some are born with them, like temperaments, if they're impulsive, more curious, or they're a bit, antisocial, they have less social skills, then they may not bother about what this is doing to others or to, their loved ones. And they may engage more into finding just something that helps them make themselves feel good. Or it could be life events, like RK's life events that he experienced. I mean, parents divorcing, no support, moving school, nobody there to help him through that process. And then he was vulnerable. So usually that's the biopsychosocial components that are linked to why people develop a drug or alcohol use problem.
In your years of practice, Dr. George, you mentioned just now during COVID, you saw in Asia Pacific an increase in suicide among young people. But here in Malaysia, what would be the most prevalent addiction that maybe young people or adults are struggling with, even before COVID, that you have seen from your own dealings with people who come to you?
Well, I mean, throughout the world, We know that cannabis is the most abused substance. In Malaysia, we're a bit unique, but that's largely because we have studies or surveys that are not really reflective of the community. So the studies that we rely on to give us data is often the studies from the National Anti-Drug Agency, or AADK. Now, AADK reports statistics from enforcement, enforcement activities. They go out, they do raids, they pick up people, do their urine, check what's positive, what's not. And so they've been reporting the most common drug of abuse in Malaysia is heroin. That's bizarre. There's no country in the world that reports that. We're the heroin central of the world, if we follow that sort of, statistics. So we've actually been mooting to have a household survey, go house to house and ask people what drugs have they used, what are they using now, or how often do they use them, look at the prevalence of dependence versus abuse versus recreation, and understand the demographics. I think the National Health and Mobility Survey did do a small study, and it did show that cannabis is the most prevalent of all substances in Malaysia. The second is kratom or katum. Down Katum is mainly in the northern states of Peninsula, especially in the Thai border. It's called kratum in Thailand. It's called katum in Malaysia, or the scientific name is mitragynine, which is taken as a drink. Usually, the leaves are made into a drink, coffee or tea or something, and they're taken as that sort of thing. They do cause dependence in those who, continues. Of course, recreational use has been there for years, for, maybe even decades. In the past, it was something that was common among paddy planters, to wake up and stay active through the day. They would use that katum leaf and, they get the job done. But now people have misused it and gone into abuse and dependence. So that's why they had to make it a drug, a legal drug. Of course, the third most common drug in Malaysia is amphetamine, and that's a real scourge. That's something that we really are worried about because it's actually on the rise, and it causes, terrible impact on people and communities. Because with the amphetamines, it's very addictive. There's a lot of craving. People, may stop for a while, but the cravings really make them relapse, and it's a relapsing remitting sort of condition, but they can be very aggressive and violent when they use amphetamines, and that can have a huge impact on families. I mean, most petty crime that's done is usually under the influence of amphetamine, and these criminals know that they have more guts, they have more disinhibition, they are more aggressive and violent, and they can commit these crimes, and sometimes it results in terrible outcomes. So that's the third most common. Then opioids are the next, and I would say something that was not researched, but I see in my practice very often, is benzodiazepines, which is your common sedatives, the sleep medicines, which sadly often is triggered not by people going to Chowkit to buy the drug, but by being dished out by doctors, and sometimes with less control. And so people get dependent on sedatives, and they have terrible outcomes as well. So these are the most common. Of course, the others we also see is ketamine, which is an anesthetic that people snort and get into a near coma sort of state and get a high from that process. So these are the most common drugs that we see.
No, I was just, as I was listening to you when you talked about sedatives. Some people need those things, maybe to help them sleep at night or other things. But at which point, where you need it and you become dependent on it, is there a kind of a point that a bridge that you cross over when you suddenly say, no, I can't sleep without that? Is it purely psychological? or is it something that you really like now you need it, that you otherwise you can't function? I mean, I'm not saying, but it's something like, when people say, I need my coffee in the morning, my brain doesn't work, kind of a thing. At which point that maybe we should be cautious about, especially using prescribed drugs.
Yeah, so I mean, basically, with prescribed drugs that are addictive, that have addictive potential, the guidelines is that you only use it for acute conditions and for short term. It's not a long term treatment. So take insomnia. I mean, if you have a sleep problem, the most common cause is secondary insomnia. That means it's due to something else. Maybe you have snoring issues or sleep apnea or a psychiatric problem, anxiety or depression. You think too much and you can't get to sleep, and all of that. So there's no purpose in treating the sleep because it's secondary. The real treatment should be for the primary disorder. Otherwise, you're just putting a band-aid on something that's going to be lasting for the rest of your life. And all you're doing is triggering off your own addiction. So one, identify what the cause is. If it's a primary insomnia, which is quite rare, there are medications that are not addictive, non-addictive sedatives that actually may be a better option, because you're not going to get better in a week or two, which is the guideline. The guideline for prescription of sedatives is not more than 2 to 3 weeks. If you have to prescribe it for more than 2 to 3 weeks, you need to think of an alternative. So that's the first important thing, because once you hit the 2 to 3 weeks, you've moved from that reward pathway thing to developing tolerance. And tolerance is the common symptom that occurs with most of these substances. You don't get the same effect, and you need to take it every day, or you need to up the dose. So yeah, I think the important thing is to get it assessed. Sleep typically is secondary. Find out what the primary cause is, treat that primary cause, and then your sleep gets better. But I think it's similar to even pain medication. The biggest addiction in the US is to prescribed medication. Prescribed pain medication. And that's your your opioids. Your strong opioids, fentanyl, and all the others, like the names, morphine and all of them. The good thing in Malaysia, we have rules and regulations about these drugs in primary care. They cannot be prescribed by GPs. So they can't be given willy-nilly to everyone who says, I got a headache and I need a strong painkiller, because you are slowly moving someone from an acute problem to a chronic dependence problem. So yeah, but I do still see in my practice people addicted to pethidine, people addicted to Tolvin, or tramadol. So those are opioids as well. They're very mild opioids, but imagine a person having to take 10, 20 pethidine a day, or go in for injection every 4 hours, and even develop fits and seizures and still come back the next day for his pethidine.
Before we continue, just to all our viewers here this morning, if you have some questions that you would like to ask Dr. George, I'm sure he'll be happy to answer some of your questions this morning with regard to addiction and the use of prescribed medication or other substances. Just do type it into the comment section. We'll try and take as many questions as possible as we continue this conversation with Dr. George. Dr. George, as we talk about what this is my at least my experience from listening to others. When people don't consciously go looking for drugs or substances to, usually it is like a friend says, hey, you try this. Somebody offers this to you. I don't know if I'm wrong, but correct me if I'm wrong. But people don't go say, okay, I want to try this. But it all starts with, try this. Do you think that just trying once can kind of trigger that pathway to becoming dependent on it? Because very often young people who also say their peers tell them, you try this. Is you try this, like you said, try the cigarette, try some recreational drugs. Can that trigger, if you're already predisposed? Can that trigger a pathway to addiction? And what should they be concerned about?
Mm. Well, I think knowledge is the most important thing. And that's why, prevention needs to have more focus and, on things that have actually shown to be scientifically evidenced. We go to the schools, tell them what happens to a drug dependent, show them the news and show them the death penalty and how people die or get rotan and everything. That doesn't stop drug use. I mean, we've had those laws and those ways of prevention for decades, and our drug use problem is only on the rise. It's not decreasing. So what we're doing is not helping prevent people from actually getting to a substance use problem. I think the most important thing is knowledge. Build the knowledge. Explain to them what these substances are, what they do to your body, and what are the most addictive, and what are the risks that happen with them, and then why people actually use them, and what are the different ways of coping with life, challenges rather than resorting to drugs. I mean, if you have in your curriculum stress management that is, tested upon in Form 5 exams or something, people become more empowered and less risked at starting off a substance use problem. It's not that they suddenly decide I want to be a junkie and that's my path in life and my career. It is things that are thrown at them in life and they don't know how to cope. No one's taught them. And why are we holding it back? Why are we trying to pretend like, look, you got to be as strong as you can and do the right things, even though we don't teach you how, So we got to put emphasis, and that comes from families and schools, on building the mental health resilience of our youth and our young ones. I mean, my experience, the youngest drug user was about 10 years old. I mean, if we want to build resilience, it has been primary school. The youngest cigarette smoker I know was 6 years old. And it was his dad who said, come have a stick. So of course, we look at drug use, it is a continuum. So there's a gateway theory. If we can prevent people from smoking, for example, till the age of 20, when their brain is fully developed, and then they make the decision, I want to be a smoker, I'm going to have my first cigarette. They've made that decision from the judgment of a developed brain, fully mature, developed brain, because the brain is a developing organ. It doesn't fully develop till the age of 20. If we can delay that, the risk of them going on to drug use or heavy substance use is almost negligible. But for a person who starts at 6, the risk of them going on to using hard substances is huge.
So how do we
Yeah.
how do we how do we build that resilience in the family? I mean, to parents who are listening this morning, how do we help them? How do they nurture their children to build resilience?
Yeah. So I mean, one is sometimes parents need, sorry, I think my internet is just.
Yeah, we lost the last sentence. Parents need to.
Is it okay now?
Yeah.
Okay. Just all of a sudden decided to give up on me. Yes. So I think it's first asking ourselves, what is our level of mental health resilience? How much do we spend, in terms of our energy, time, and effort in building mental health skills for ourselves? And if we don't, then we need to start doing, because we whatever we do in our day-to-day life will be what children follow. The learning theory suggests that if they notice parents are always getting angry, frustrated quite quickly, and irritated, and that's their way of coping with stress, or comfort eating with a lot of cake, they do the same thing. So we need to change our own perspective on what mental health we have, what our skills are, and then build it as a pattern that children can follow. Secondly, we need to put more effort into building, new mental health skills for our children. I mean, there are things like exercise, regular exercise. That's something that parents can actually guide children from an early age. The worst thing that they can do is give them a gadget and say, this is your exercise for the day, and this is your, relaxation. We know studies have shown more than 2 hours of gadget, video games, or social media is going to trigger depression or anxiety or mental health problems. So the evidence is already there. You don't have to reinvent the wheel and try and look for, my surrogate babysitter is this gadget. So start getting involved and engaged, and the best way is through things like exercise together, family exercising together, praying together. I think it's very important. Putting that part into as a family. This is the way you can work on coping as well. And then things like meditation, mindfulness, and your breathing exercises. There's no harm in learning these things. These things are for free. You can pick them off the internet or on apps. And when you teach your children at the young age of maybe 3 or 4 these things, build it as a pattern for their life, and they can cope with things that life throws them. So yeah, I think emphasis on that is really essential.
Now, coming back to the family, how do we may not know, how do we recognize if someone is an addict? What would be some of the signs and symptoms that one should be looking out for, or be worried if they see these things, and try to get help for somebody who may be on that pathway?
Yeah. Well, I mean, typically addiction will have consequences. Again, it's the whole gamut: physical, psychological, behavioral, financial, and social. So, socially, they may be isolating themselves more, they're not communicating very much, or, they're locked up in their room most of the time. Then they may be financially not coping very well and needing a lot of money every now and then. And then psychologically, they may be more irritable, angry, sort of emotional as well. And then physically, they may, suddenly start to lose weight and appetite. And so depending on the type of drug, there are various different physical impacts. One thing that we as addiction specialists know is that there is differences and changes in the eyes. Every drug has an eye sign. So, for example, with cannabis, it causes redness of the eyes. Of course, most people who use cannabis are aware of this, so they carry around eye drops, and every now and then they're using eye drops. So okay, what's this eye drop thing? I mean, he doesn't have cataract or glaucoma or something, so why is he on this eye drops at the age of 18? So yeah, I mean, then you have the other substances like opioids, which actually cause, if they're intoxicated, constriction of the pupils, so the pupils are a bit small. Of course, you need to know what pupils are and where they are to be able to detect that. But they're the little black part in the middle of the eye. And so there's a typical size of 2 to 3 millimeters. When they get smaller than that, then they're suggestive of maybe intoxication. And when they get dilated, they're typically suggesting withdrawals. That same eye sign is the opposite for amphetamines. So amphetamines, they get dilated when they're intoxicated, and then constricted when they're in withdrawals. So yeah, so these are some of the different signs, but typically behavioral and psychological symptoms.
And if they do see these things, of course, I mean, not everyone is an expert to be able to identify immediately. What would you say? I mean, how would parents or siblings open the topic for discussion with that person? What would you suggest? Because sometimes people can resist. They say, okay, let me take you to go and see Dr. Philip George. They may resist, say, no, I'm not coming. I've no problem. But how do we approach in a way to allow the conversation to begin, at least with that person? Are there some tips that you could offer?
Yeah, I think the most important thing is to express your concern. Look, buddy, I think I noticed some changes, and and they really are not the same, suggesting that you're the same person as before, and I'm concerned. I'd really like to help. Maybe is there something that you'd like to talk to me or discuss with me, or I can bring you to see someone. Give them that opportunity to express and talk about what they're going through, but especially tell them what your concerns are. And don't beat around the bush, but tell them transparently and directly what you think the issues are. And of course, if they're defensive and rejecting, and tell them, well, anyway, I'm here, and if you do need to discuss and talk to me about it, then we can maybe I'm ever willing to help. Sorry, but I was wondering if Ruben can just share the slide
Sure.
that I double. Okay, so if we can go on to the next slide, you think I can control it, or maybe the next one, the slide 2?
Yeah, you can change it, Dr. George.
Oh, okay. Oops. I am trying to change it, but I can't seem to do that. Okay, I am trying to get the next slide. Sorry.
On the it's on the device that you are showing that you're projecting that screen. If you can change it there on that device, let's see
Okay.
if you.
Oh, I see. I see what you mean. Yeah. Okay.
Okay,
Okay, has
that's
that
it. There you go.
worked? Oh, good. Okay. So essentially, people go through different stages. And this is not only true for addiction, it's also true for chronic relapsing illnesses like diabetes, hypertension, all these illnesses, chronic relapsing illnesses, people go through different stages. For example, if you've just been diagnosed as being diabetic, you might be actually in pre-contemplation where you're saying to yourself, that blood test was all rubbish. It was done at the wrong time, wrong day. Doctor didn't read it right. All these medications are useless. I don't really need them. I can do other things to help my diabetes. I don't need to change my diet and start exercising. So you are in pre-contemplation. You decide that no, it's not a problem. You're not going to make any lifestyle change to address the current illness that you have. Then you may go to contemplation when, for example, you notice, some wound in your foot that's not getting better, or your kidney function is starting to deteriorate. And then you think, oh, well, maybe I do have a medical problem, diabetes, that I have to take some steps. But you need to get to determination to make those steps. And then you go to action where you make those lifestyle changes. You start exercising, you start taking your medication regularly, you get by the referral flux, you check your blood sugar every day, and then you get onto some maintenance. But of course, some people with diabetes or with drug addiction, it may be Christmas time and there's a turkey and there's other wonderful cake, and they lapse and they get into high blood sugar again, and they go into ketoacidosis, you get back in the hospital, they've had a relapse. And that's typical even in drug and alcohol addiction as well. So people in pre-contemplation really the only thing that you may be able to do is just advise them to be safe with their drug or alcohol use. Look, maybe you want to avoid drinking during the day, drink in the evening, cut down your drinks, count your drinks, maybe avoid, the illicit alcohol, the cheap liquor, because they affect your liver and everything else worse. And, try and maybe have a day or two off of your alcohol. That's the only advice you can give them. But perhaps, also tell them that when you're ready to try and make some changes, then in your contemplation, let's go and see someone together. And of course, in determination and action, then we can put our treatments into place, which typically involves two phases. One is detox, and second, relapse prevention. The both have to go hand in hand. You cannot do detox and omit relapse prevention. People just relapse if you only do detox. So detox is basically getting them through the withdrawals, the craving, the withdrawals that occur in the first 1 week to 2 weeks, especially. We want to help them through that phase. Sometimes it's with medicine, sometimes it's with therapy. The combination is the best. And then we go on to relapse prevention. And depending on what substances and how long they've been using, that relapse prevention may go on for months or even years. Because just like diabetes, it's a chronic relapsing illness.
Yeah, it sounds very complicated, but I'm just trying to understand. I mean, in simple ways, from the time of, for example, let's take from the time of of just being a recreational user.
Mm.
From your experience, how quickly can it turn to become an addiction?
Oh, well, I mean, again, it depends on the vulnerabilities. So if people have those current vulnerabilities and, of course, availability, then it can progress on to the next phase. Yeah. So, but in some, it may not necessarily go there because they maybe have the mental health resilience to, defeat that progression. And they may have the environments and, other things that actually help as well.
Now, coming to a more practical question in that sense, as we have this conversation, Dr. George, I mean, I just want to break this question into two parts to our viewers here. If I am someone who is struggling with substance dependence, what would you say? And the second part of the question is, if I have someone in my family who is struggling and I can see and refuses any form of help, what can I do to help?
Yeah. Yeah. So if I'm meeting someone who has a drug or alcohol addiction or problem, and they're willing to talk about it, that's the first biggest important step. The awareness and understanding and the seeking for help. So typically, I would make use of that period or that opportunity to start focusing on sorry, what we call as motivational interviewing, teaching him, okay, why are you making this decision? Let's do a feedback form. What's the good of your drug use? What's the bad? And maybe get, maybe your loved ones involved. And so you have a good list that you keep, maybe even frame up or put in your phone. You put it somewhere that you can refer to, because, you can actually have craving and desire that obliterate the bad effects of the substance use. It only makes you think of the good, that you felt high, you felt comfortable, there were no problems in life, but it omits the fact that your relationship is going down the drain, your work, there are issues, financially you're gone, so put that down in paper, have that available for you to look at and review. The second step is also identifying, who are you doing this for? Is it for you or for your family? Because if you're doing it for someone else, I mean, you might have an argument with your family one day and then say, why the hell am I doing all this? I'll go and have my drink. So you've got to, get married to this decision. You need to take the responsibility yourself. You need to decide, I am doing it for myself, for me to recover. And then often in my practice, I would tell them, well, there's a menu of things to choose from. Because I'm not going to be the prescriber. You're going to decide the path that you want to take. So, one, rehab; two, maybe you can do it outpatient; three, you get into the hospital, do detox; four, we can do medication as outpatient, but you need to have your family. What do you prefer? So when you give that option to the person, then it is his decision, not mine. It's his decision. If things don't work, it's just him who decided, right? So you can't come back and say it was you who decided this and told me this and didn't work and blah blah blah. So, and then finally, self-efficacy, which means basically, most people who come to me with a substance use problem have already tried several times trying to quit. They've had success for about a week, then they start drinking again, or they stop for about a month and then they start using again. So it is not like they haven't tried; they've done it before. And so most of them are coming in a defeated, sort of mindset. I can't do this. I've tried so many times and I can't get it. So we need to give them the self-efficacy to make them feel confident about being able to do this. And that's where I typically link them in with others who have done it. So Narcotic Anonymous, Alcoholic Anonymous, Smart Recovery. These are people who've been there, done it, recovered, and helping others to recover. And they don't charge a cent; it's free. So yeah, so doing it together in a group is even more powerful. And so these are the different steps that typically we take. Sorry, so then you said about the family members.
Families, yeah. What families can do if they? How can they assist?
Yeah, so I think the important thing is to first have that conversation. And then start putting some boundaries. Okay, look, I understand you like your drug use. We identified that things are changing. You maybe admitted that you're using, or you don't want to admit. That's fine, but we've seen some stuff in your room. We caught that smell, and whatever. So we're going to put some boundaries. These are the things that need to be addressed, because in a family we can't have this to carry on. And if you continue using, then sorry, you'll have to live outside. I mean, that decision has to be decided by the family themselves, but in discussion with the person. And then, to ask him what he wants to, put as boundaries for himself as well. If you're being aggressive or violent in the house, we're going to call the police. We can't have you stay in a house anymore. Or, we need to put safeguards. We're not going to give you money if you've gone beyond the amount that is stipulated. And so those boundaries are essential, because most families end up being enablers. They unconsciously are helping the person to continue their drug use. They have some suspicion in them back in the mind. They don't want to confront, because they hope that there'll be some miracle and tomorrow he'll change and become saint-like, and stop using. And so there's no intervention, and they just continue to hope, and they're feeding the addiction. Because the person who's addicted is saying, well, my family doesn't care too much. I'm happily using. They, appreciate me coming home drunk and intoxicated. And so I'm just going to continue doing it. So an enabler basically encourages that problem. And typically, sadly, most people who have gotten into a dependence need to hit some rock bottom before they actually think about that contemplation and determination to change. It's sad that that happens, but sometimes when their liver's a bit bad, or they've had the biggest argument of their life, or they lost their job, or they got into an accident, and that's when they think about change. It's sad that that has to happen sometimes, but boundaries are really important.
You talk about Narcotics Anonymous, Alcoholic Anonymous. I'm just going to kind of relate to. I remember many years ago, my dad used to be involved. I don't know if you remember. It's Pusat Serenity,
Yes,
where
yes,
a
yes.
drug, the government initiative. He used to say that he used to go there to help and all. He used to say that a lot of them keep coming back because yes, for that period they get detoxed, and then they release them and they go back to the same environment, and then they get addicted, and then they keep coming back. It's like a little pattern.
Yeah.
I also remember that being in the parish, people call, especially travelers, visitors to our country. Suddenly they call the church and says, "Do you have an AA group?" What is the importance of community support? Because I know that people who have recovered from addiction, especially in AA, they continue to go. They continue to go for AA meetings. They don't stop, even though they have they said they have beaten the problem. They said they need that community support. What's the importance of community support for somebody who wants to get out of addiction?
Yeah, so I mean, it plays a very, very huge role, actually. I mean, in my practice, basically, I would combine all the interventions together. So, biological, meaning medication, especially for detox. Sometimes there are medications to cut craving, and also the underlying, psychiatric problem also can be addressed, but also counseling. So I refer to a drug and alcohol counselor. We don't have that many in Malaysia, but the few that I do know work very closely with patients. And then thirdly, I would refer them to the peer support groups, AA or NA or Smart Recovery. So there they will meet others in their journey of recovery as well. It's really important because, typically for most families, for example, if somebody just decide to get into treatment and recover, a month or two down the line, or maybe even 3 months, families will start, maybe thinking everything's back to normal. So that, the praise and the reassurance and the support and all of that they were giving earlier is suddenly lost. Because why do you want to do that for, months on end anyway? So nobody's going to say, well done, really happy that you're not drinking after 6 months or after 5 months. So that support, I mean, people don't realize that that's the time when they're the most vulnerable. It's called the honeymoon period. The first 3 months to 6 months is the honeymoon period when, maybe there's a lot of attention focused on the person. They're doing well. They feel proud of themselves because of what others are saying. And then suddenly there's silence. That's when relapse occurs. So that's when, the community, the support networks know this and they provide that support. They have a buddy system. You can call on someone who's almost like, your own family member. Middle of the night, you have craving, you're thinking of using, call this person, and that the person's there just talking you through and helping you to rethink your craving and desires.
So where can people go for help, Dr. George? I mean, you talk about AA, you talk about the other groups. I know not everyone is able to afford a one-to-one counselor or a psychologist. Are there government initiatives, this kind of services provided, this kind of groups? Where can people go to get assistance or to take someone who needs assistance?
Yeah. So I mean, basically, most university hospitals, UKM, UH, and the larger general hospitals have addiction psychiatry units. They're close to about 15 addiction specialists now in the country. So they run their own addiction clinics, and you can actually see them in the general hospital. It's usually 5 ringgit registration if you have a referral letter from a clinic kesihatan. So of course, if detox inpatient is required, all that will be arranged by the unit itself. But the support, the community support, I think that usually, I mean, not all addiction psychiatrists that I know recommend it. I typically like the combination because I don't just focus on the biological. I like to think of addiction as a holistic thing. It's a combination. So I insist that people also get into, the peer group support, the Alcoholic Anonymous or Smart Recovery. Smart Recovery is pretty new to Malaysia. It's worldwide, started in the US, and it's focused on building skills to deal with preventing relapse. It's run by recovered addicts. And in Malaysia, it was only started 2 years ago by a person who's been in recovery for many years. I think their approach is quite, especially for the intellectual crowd, that would be a real useful approach. Alcoholic Anonymous also is very powerful in providing support. And I mentioned the buddy system, that's with the Alcoholic Anonymous and Narcotic Anonymous. They're all online. So if you go Alcoholic Anonymous Malaysia, you'll be able to find where their meetings are. I think there are only 3 meetings in KL and 1 in JB. I think there's 1 in Penang as well. And most of these meetings are now online as well. So you can go online, register. Of course, there's a process, for making sure that you're not a scam sort of thing. But and then you get on, and you can choose to put your camera off or put a different name as well.
We're just taking 1 or 2 questions from our viewers. There's Leo Tua who's asking. We've been talking about substance abuse. Now his question, I think, is very practical in the sense that can someone be addicted to work?
Yeah. Well, not necessarily. I mean, again, it has to be something that triggers your reward pathway. So unless you are feeling ecstatic about work, I don't think you can get into it. But there's a different category called workaholics. I mean, you see, addiction and obsessive compulsive behaviors are very close. The difference is in obsessive compulsive behaviors, it's not something pleasurable. You do more and you get more and more pleasure. I mean, you go to work and you work 10 hours instead of 8, you don't get, sort of excessive pleasure from it. Like if you maybe have exercise or have a good meal. So it is a little different in terms of obsessive compulsive traits may be part of a perfectionist. So your workaholics are typically your perfectionist people. They overdo things, but to their own detriment,
Mm.
because it catches up. I mean, anxiety builds, depression builds. Physically, you're going to end up with problems, hypertension, diabetes, all those A-type personalities who overthink their work and, doing things and don't take breaks and don't relax. They end up with other medical problems.
There's another question, Dr. George, from Jacinta Francis here. She's asking the question
Yeah.
from your experience, or if there are statistics to show how serious is marijuana addiction in Malaysia? Is that a big problem in Malaysia?
Yeah, I mean, again, we don't have that household survey, so we are not completely sure. But yeah, the National Health Morbidity Survey shows that it's the most common drug of abuse, and I believe it's on the rise. I mean, there are a lot of influences. Media is definitely an influence. Plus, many countries have actually legalized marijuana, but that is medical marijuana. That
Medical.
means it's prescribed. There are only very few places where recreational marijuana is legalized. There may be some logic in that, because if we can legalize cigarettes and alcohol, actually marijuana recreational use has got less impact than cigarettes and alcohol. So but it needs a certain level of maturity. You
Hmm.
know, I mean, if you're going to be, even drinking or starting to smoke, you need to have some maturity. That you don't drink every day, you don't drink excessively, so all of that needs some level of maturity. That's why we have enforcement on the age of when people can buy and purchase and smoke or drink, because that's when we know people are mature enough. So the same with marijuana. I mean, if perhaps more countries will legalize it, but there has to be some enforcement about its use. And and I think Canada has shown the way that when you do put enforcement, you sell it, and revenue comes back to the government as well. You can then have controlled recreational use of marijuana. you know. But yeah, our community, I think maybe I'm not completely ready. I mean, people in the rural areas and all that, I mean, imagine having marijuana to use recreationally. They need to be educated, and they need to have a school system that focuses on mental health, resilience, and all the other things that we talked about. And we don't have
Is,
that. We can't. Yeah.
is the use of marijuana for medical purposes being explored in Malaysia from your experience? From your
Yes.
okay,
Yes. It's being explored. Because our neighbors already are going to start, Thailand and
okay.
Singapore. So, yeah, I mean, I think there is a valid reason for it. I mean, especially for people with terminal illness and intractable epilepsy. I mean, the users are very small. It's not
Okay.
every other condition can be treated with marijuana. This is very select, terminal sort of condition.
We have another question, Dr. George. I think this comes down more in a more practical sense with young people and computer gaming. Uh,
Mm.
how do we help young people so that they don't get addicted? Or I'm not sure whether the word is addiction, but the whole life revolves around on computer gaming so much so that
Yeah,
everything else is neglected. How do we address something like that in the family?
yeah.
I mean,
Yeah,
it's not
so
just young people. I think also adults also. It's the same problem.
yeah, that's true. I mean, the sad thing is, you watch families come in for dinner and everyone's on their gadget. There's not a single person talking to each other. And so it starts from maybe even family behavior. It's learned that families do this, so why can't we? Um, but yeah, I mean, children are not going to reply emails and get timetables. They're going to use their gadgets for other things, and video gaming is one. Video gaming is, it actually has been shown to be helpful to manage some stress, and especially during the lockdown, it also has been helpful in engaging people and building social connections. Because now there are video games where you're actually communicating with others, you're competing with others, you're talking to others, and so you're meeting people from around the world. It's like a social media network together with video games, but it has to have some boundaries. I mean, everything that's good also can be bad in excess. So, yeah, typically we advise not longer than 2 hours. Have a negotiation with your son or daughter from a young age. You know, 2 hours, not or even 1 hour. I mean, should suffice. And then give them maybe a reward on when they do well. You get a 2 hour day, or you get for the holiday you get maybe a additional half an hour, and they will appreciate that. But make it something that they are looking forward to, not something that is a given. It's because it becomes almost like it's like breakfast. If I don't have my gadget, it's like I'm not having breakfast. So don't make it something that's entitled. It is something that is like a reward. And then they learn the value of these things.
I mean, it is very tough, especially like I said, when you go to the device has become the best babysitter for many parents. At least pre-pandemic, when you go to a restaurant and you want to keep the child quiet, you just take out your phone and give it. And the child is like completely oblivious to everything that's happening. You have a peace of mind. You have a peaceful dinner. The child is occupied, but we don't realize that it also could cause other forms, effects on young people.
Father, I have a confession. When my daughter was, I think she must have been about 15, I think 15 or 16, and we went to a friend's house, and she went to play with somebody who was her own age in the room and all that. She came out and she talked to me later, and she said, "Daddy, why didn't you ever teach me about video games? I just played my first video game and I enjoyed it. I loved it." So I said, "Well, I don't know video games myself. I don't play them. But if you like, we can explore them together." But she forgot about that and went back to the things that we typically do: exercise regularly. I mean, she was a bit of social media, but introduction can be guided, and it's the way we introduce. It's sometimes in families, it's like a prestige issue. My 3-year-old is using his gadget. I'm so proud of him. Look at him on his gadget. What's so proud about a 3-year-old on a gadget? There's no pride in that. I mean, if he swims the length of the swimming pool, I'd say you have every right to feel proud of it. But a 3-year-old on a gadget, it's sad what people are thinking. Material wealth and things have taken over sometimes.
Yeah. Dr. George, I know I've taken more time than we agreed. I know you have a practice to to continue. But just one last question. We'll take one last question, and then I'll let you go. I'm sure somebody is waiting to see you. The question is from Angeline Anthony. If a drug addict, for example, someone who's addicted to marijuana, kind of says, "Okay, I will stop by myself," is that even possible? There are people who think, "Okay, I don't need help. I can do it." Is that even possible?
Yeah. So we have the criteria to make a diagnosis, and usually, if it is meeting the criteria of dependence, that means it has to be 1 year, duration, and meets the certain criteria. Then it is an illness just like diabetes and hypertension and all the other illnesses. And people don't recover from diabetes and hypertension. I mean, actually, 5% may. And that's why you get these reports. I've recovered from my cancer. I've recovered from my diabetes. I didn't even take any medicines. Yes, 5% need, recovery on their own. It's the P is equal to 0.05. By chance, 5% from any condition will recover. But how sure are you that he's in the 5%? So, I mean, this is what happened in Pusat Serenity. When they ran Pusat Serenity, the results were 5% recovered. But 95% were in and out, were continuously coming back and spending millions and billions of taxpayer money for a treatment that doesn't work. That only works for 5%, which even if you do nothing, 5% will recover. So, yeah, I mean, I would say, Angeline, maybe tell him, look, we know that it doesn't, it's only about 5% that people recover. You want to try, go ahead. But if you can't, please work on real treatment. That will help you.
Yeah. Thank you very much, Dr. George. I mean, just some final words from you. We always hear these words: prevention is better than cure. We hear this. To all our viewers here, what would you say? As we conclude this conversation, what do we do to prevent from someone someone becoming addicted? What steps can they take to prevent this even happening in a family or among young people or young adults?
So sorry, that question was to me.
Yes, yes.
Yeah. So I mean, I recently helped form a youth movement in Malaysia under the National Coalition of Mental Wellbeing. It's called the Mind Matters Network. We formed the Mind Matters Club in my university, and it starts with actually empowering students by students on mental health resilience. So, they have speakers on yoga, on mindfulness, meditation. They do activities like dance and, all those sort of things and build mental health skills. So we're taking this nationwide, and we've now come up with a book on youth mental health. So, I think one of the steps is empowering youth. If parents and schools are not going to take the effort, peers can do it. Youth who are passionate about mental health can do it. And we have numerous. Now we have recruited almost about 30, 40 youth from different institutions. It's just like the climate, crisis thing. It's the youth who are pushing these movements. And the mental health for youth is actually now, well, we're starting off with youth, building, youth movements around in schools and other places to build mental health resilience. I mean, those in power and all don't seem to think it's important, so let the youth do it.
Yeah. Dr. George, thank you very much for this interesting conversation this morning on addiction, especially in the family. And I'm sure our viewers have benefited. I'm sure they have many other questions, but we are running out of time, and I know that you have to go back to your practice. You put aside this time for us. Thank you so much for taking time off in the Saturday morning to be with us to talk a little bit about addiction. And I think this is a problem that often is not talked about. We think that we can solve the problem by ourselves. Because there's also an issue of shame. Families don't want to talk about it. There's an issue of shame. If it happens in my family, it shouldn't happen in a good family. It shouldn't happen in a religious family, for example. A family that is, people think that it shouldn't be happening, and they don't want to talk about it. So an opportunity like this gives us the place where we can talk about these things and let people think and see how they can get help. And we are truly grateful for the work that you do. And also for taking time off to be with us. So to all our viewers out there, if you are struggling, get help. Dr. George has mentioned, there are different places, different organizations, there are different hospitals. If we have family members who want to help their loved ones, also talk to them, open the subject, don't hide the subject. And offer assistance, offer love to them. I think it's not something to be stigmatized about. It is an issue that a lot of people struggle with, and something that can be treated. I just heard from you, it's something that is treatable.
Absolutely.
That's something.
Father, sorry, I
yes.
think with the handbook, I actually have an e-copy coming out soon.
Great.
I was wondering if I can send that to you and you could share it with the whole congregation. In fact, I have about 4 books. Together with some of my ex-students, and so on anxiety disorders, on depression, on schizophrenia, and on youth mental health. So I'll share all of them with you, Father.
Thank you so much, Dr. George. Do look out. We will post them on our Facebook page, Catholics at Home.
Yes,
Do look
yes.
for us, and we'll post those ebooks. Thank you very much for sharing these things. I'm sure our viewers will benefit, especially as we come out of this lockdown and towards recovery. It's not just a recovery of the economy, but it's also a recovery of our mental state from lockdown to getting back to some level of normalcy. Before we end, Dr. George, just let's say a prayer together. We just pray for all those people who are working in this area, those who are struggling families, and ask the Lord to bless them. In the name of the Father, Son, and the Holy Spirit. Amen. Dear Lord, we thank you for this conversation. We thank you for people like Dr. George and many others who are out there helping those who are struggling with addiction. Give them the strength, give them the wisdom, the inspiration to help others. We pray for people who are struggling with addiction, that they may reach out of themselves to seek help. We pray for families who are struggling to cope with these problems. We ask you, Lord, to be close to them so that they can also help one another to come out of this. Lord, we ask you to bless each one of us during this time. Keep us safe. We pray for all our young people that they may truly be resilient in these times, to be able to live the life that you have blessed us with, to live the life, the fullness of the life that you have given to us. Mary, our mother, we continue to ask you to pray for us. We make this prayer through Christ our Lord. Amen. In the name of the Father, Son, and the Holy Spirit. Amen. So thank you very much, Dr. George. Thank you, everyone, for joining us this morning. Do look forward next Saturday, same time, 10:30. We'll have another topic to talk about. Do look out on our Facebook, on our YouTube channels. Subscribe, like, to get reminded and to share it with your friends. Until we meet again next week. Bye, everyone.